Welcome to this therapeutics revision quiz on dyspepsia. In this video, we'll explore key pharmacotherapy principles and clinical treatment guidelines that guide the effective, evidence-based management of dyspepsia. After completing these questions, learners will be able to understand pharmacotherapy management, apply established clinical treatment guidelines, identify appropriate drug selection and dosing regimens, recognize potential adverse effects and drug interactions, address management in special populations, and implement effective patient monitoring strategies. The quiz includes 15 scenario-based multiple-choice questions. Each question has 5 options, followed by the correct answer and a brief explanation. So, let's get right into it. Question 1. Mr. Anderson, a 47-year-old man, presents with persistent epigastric pain and early satiety. He reports using ibuprofen daily for osteoarthritis. He denies vomiting or weight loss, and examination is unremarkable. A urea breath test is negative for Helicobacter pylori. What is the most appropriate next therapeutic step for this patient's dyspepsia? Option A, stop ibuprofen and start omeprazole. Option B, continue ibuprofen and add ranitidine. Option C, start metoclopramide only. Option D, prescribe sucralfate and continue ibuprofen. Option E, add misoprostol for gastric protection. The correct answer is option A, stop ibuprofen and start omeprazole. This is because NSAIDs like ibuprofen can directly irritate the gastric mucosa, leading to dyspepsia and ulceration. Proton pump inhibitors such as omeprazole are recommended in the BNF for treating NSAID-induced dyspepsia after discontinuing the offending agent. Continuing ibuprofen with other protective agents does not address the root cause, making those options less effective. Question 2. Mrs. Brown, aged 35, presents with upper abdominal discomfort, bloating, and nausea for several weeks. She is otherwise healthy and takes no regular medication. A stool antigen test confirms Helicobacter pylori infection. What is the first-line eradication regimen for this patient? Option A, omeprazole, amoxicillin, clarithromycin for 7 days. Option B, ranitidine, amoxicillin, clarithromycin for 14 days. Option C, esomeprazole, metronidazole, amoxicillin for 3 days. Option D, omeprazole, metronidazole, tetracycline for 7 days. Option E, lansoprazole only for 4 weeks. The correct answer is option A, omeprazole, amoxicillin, clarithromycin for 7 days. The explanation is that standard triple therapy with a proton pump inhibitor, amoxicillin, and clarithromycin for 1 week is recommended as first-line eradication according to the BNF. Other regimens, such as ranitidine-based or shorter durations, are less effective at bacterial clearance. Monotherapy with a PPI or tetracycline combinations is reserved for second-line or resistant cases. Question 3. Mr. Hughes, aged 63, reports recurrent heartburn and epigastric burning. He takes aspirin 75 mg daily for secondary prevention of myocardial infarction. Endoscopy shows erosive gastritis. Which drug combination is most appropriate for gastroprotection while continuing aspirin? Option A, ranitidine 150 mg twice daily. Option B, omeprazole 20 mg daily. Option C, misoprostol 200 micrograms 4 times a day. Option D, sucralfate 1 gram 4 times a day. Option E, esomeprazole plus ibuprofen. The correct answer is option B, omeprazole 20 mg daily. This occurs due to omeprazole being the preferred PPI for gastroprotection in patients requiring long-term low-dose aspirin. Proton pump inhibitors significantly reduce gastric acid secretion and ulcer risk compared to H2 blockers or cytoprotective agents. Misoprostol and sucralfate are less tolerated or less effective, while adding ibuprofen would worsen mucosal injury. Question 4. Mrs. Lopez, 55, presents with long-standing functional dyspepsia. She has tried PPIs and H2 blockers without relief. She is not taking NSAIDs or other medications. What is the next step in management to improve her symptoms? Option A, trial of low-dose amitriptyline. Option B, add metoclopramide long-term. Option C, start omeprazole at higher dose. Option D, begin triple therapy for Helicobacter pylori. Option E, prescribe antacids regularly. The correct answer is option A, trial of low-dose amitriptyline. The reason is that low-dose tricyclic antidepressants like amitriptyline are effective in refractory functional dyspepsia by modulating visceral hypersensitivity and pain perception. Increasing PPI doses or adding metoclopramide long-term is not beneficial and may cause adverse effects. Antacids provide only transient relief and do not address the underlying functional component. Question 5. Mr. Johnson, 72, presents with dyspepsia and early satiety. He takes naproxen, ramipril, and warfarin. Endoscopy shows gastric ulceration. Which of the following drugs is contraindicated in his management? Option A, omeprazole. Option B, ranitidine. Option C, sucralfate. Option D, misoprostol. Option E, metoclopramide. The correct answer is option D, misoprostol. The explanation is that misoprostol is contraindicated in patients on anticoagulants like warfarin because it can exacerbate gastrointestinal bleeding. While it provides gastric protection in NSAID users, its prostaglandin-mediated effects can worsen mucosal irritation and bleeding risk. PPIs and H2 blockers are safer alternatives for ulcer management in such patients. Question 6. Mrs. Taylor, aged 40, presents with upper abdominal pain, especially after meals. She is on sertraline and ibuprofen and self-medicates with over-the-counter ranitidine. All of the following are appropriate management steps except one. Identify the incorrect step. Option A, discontinue ibuprofen. Option B, start omeprazole for 4 weeks. Option C, test for Helicobacter pylori. Option D, continue ranitidine indefinitely. Option E, review sertraline only if symptoms persist. The correct answer is option D, continue ranitidine indefinitely. This is because long-term use of ranitidine is no longer recommended due to both safety concerns and its reduced efficacy compared to proton pump inhibitors. PPIs like omeprazole are first line for managing dyspepsia, particularly in NSAID-related cases. Chronic H blocker use without review or underlying cause management is inappropriate and potentially harmful. Question 7. Mr. Clark, a 66-year-old with a history of peptic ulcer disease, presents with black stools and dizziness. He takes naproxen and prednisolone. Endoscopy reveals a bleeding gastric ulcer. After stabilization, what should be the long-term prophylactic therapy to prevent recurrence? Option A, omeprazole maintenance therapy. Option B, ranitidine as required. Option C, sucralfate after meals. Option D, metoclopramide when necessary. Option E, misoprostol only. The correct answer is option A, omeprazole maintenance therapy. The explanation is that patients requiring long-term NSAIDs or corticosteroids benefit from continued PPI therapy to prevent ulcer recurrence and bleeding. PPIs offer superior acid suppression and mucosal healing compared to H2 blockers or sucralfate. Misoprostol is effective but poorly tolerated, and intermittent or PRN therapy provides inadequate prophylaxis. Question 8. Mrs. Davis, aged 70 with renal impairment, eGFR 35 ml per minute, presents with mild dyspepsia. She is on enalapril and aspirin. Which pharmacological choice for symptom control is most appropriate given her comorbidity? Option A, cimetidine. Option B, aluminium hydroxide. Option C, omeprazole. Option D, magnesium trisilicate. Option E, ranitidine. The correct answer is option C, omeprazole. The reason is that PPIs are safe and effective in patients with renal impairment, as they do not require dose adjustment and have minimal nephrotoxic potential. H2 blockers and magnesium or aluminium-based antacids should be avoided or used cautiously due to accumulation and toxicity risk. Therefore, omeprazole remains the preferred and safest option in this setting. Question 9. Mr. Reed, age 28, presents with recurrent dyspepsia. Endoscopy shows no organic cores. He smokes 10 cigarettes per day and drinks coffee frequently. He takes no medication. Which of the following non-pharmacological measures should be emphasized first? Option A, reduce coffee and stop smoking. Option B, begin gluten-free diet. Option C, avoid high-fiber foods. Option D, fast intermittently. Option E, avoid dairy and citrus fruits entirely. The correct answer is option A, reduce coffee and stop smoking. This is because smoking and excessive caffeine intake are known to lower lower esophageal sphincter tone and increase gastric acid secretion, worsening dyspeptic symptoms. Lifestyle modifications targeting these habits often provide significant symptom relief before pharmacotherapy is needed. Other dietary restrictions, such as gluten or fiber avoidance, are unnecessary without clear intolerance or celiac disease. Question 10. Mrs. Evans, a 60-year-old with chronic heart failure, reports dyspepsia while on furosemide, digoxin, and ramipril. Which medication is least suitable for treating her dyspeptic symptoms? Option A, omeprazole. Option B, ranitidine. Option C, sodium bicarbonate. Option D, esomeprazole. Option E, lansoprazole. The correct answer is option C, sodium bicarbonate. The explanation is that sodium bicarbonate is contraindicated in patients with heart failure due to its high sodium content, which can cause fluid retention and exacerbate cardiac symptoms. PPIs and H2 blockers are safer alternatives with minimal systemic sodium load. Using sodium-containing antacids in such patients may lead to worsening edema or decompensation. Question 11. Mr. Harrison, aged 45, presents with refractory dyspepsia unresponsive to initial PPI therapy. He has tested negative for Helicobacter pylori. Which of the following would be the most appropriate next pharmacologic strategy? Option A, switch to another PPI. Option B, add metoclopramide. Option C, combine PPI with H blocker. Option D, start sucralfate only. Option E, stop all medications immediately. The correct answer is option A, switch to another PPI. This is because switching to an alternative proton pump inhibitor can improve acid suppression in patients who fail initial therapy due to variable bioavailability or CYP2C19 metabolism. Metoclopramide and H2 blockers are less effective for true PPI-resistant dyspepsia. Stopping therapy abruptly or using sucralfate alone would not adequately control symptoms. Question 12. Mrs. Miller, aged 32, is 20 weeks pregnant and reports epigastric burning. She is otherwise healthy. Which therapy is most appropriate and safe in pregnancy? Option A, omeprazole. Option B, ranitidine. Option C, sucralfate. Option D, sodium bicarbonate. Option E, misoprostol. The correct answer is option B, ranitidine. The explanation is that H receptor antagonists like ranitidine have an established safety record during pregnancy and are recommended for persistent dyspepsia unresponsive to lifestyle measures. PPIs are generally reserved for refractory cases but are less well studied in pregnancy. Misoprostol and sodium bicarbonate are contraindicated due to risks of uterine stimulation and fluid overload respectively. Question 13. Mr. Scott, aged 50, presents with nighttime heartburn despite omeprazole 20 mg daily for 8 weeks. He does not smoke or use NSAIDs. What is the most appropriate adjustment to improve symptom control? Option A, increase omeprazole to 40 mg daily. Option B, switch to ranitidine. Option C, add alginates at bedtime. Option D, stop therapy for 2 weeks. Option E, add misoprostol. The correct answer is option C, add alginates at bedtime. The reason is that alginate-based preparations form a protective raft over gastric contents, preventing nocturnal reflux symptoms that persist despite adequate acid suppression. Increasing PPI dose may not resolve positional reflux-related symptoms. Ranitidine or misoprostol additions are less effective and not routinely recommended for this indication. Question 14. Mrs. Wilson, aged 67, presents with epigastric discomfort and a 2 kg weight loss over 2 months. She has hypertension managed with amlodipine. Which of the following statements about her dyspepsia management is incorrect? Option A, alarm symptoms warrant urgent endoscopy. Option B, empirical PPI can be tried first. Option C, Helicobacter pylori testing is indicated. Option D, review drug-induced causes. Option E, avoid delaying endoscopy due to mild symptoms. The correct answer is option B, empirical PPI can be tried first. This occurs because patients over 55 years with alarm features such as weight loss should undergo urgent endoscopy rather than empirical therapy. Testing or delaying definitive diagnosis risks missing underlying malignancy. Therefore, while PPIs are safe, they should not replace prompt investigation in such presentations. Question 15. Mr. Morgan, aged 44, has persistent dyspepsia and anxiety. He was treated for Helicobacter pylori 6 months ago with triple therapy. Symptoms recurred despite omeprazole 20 mg daily. All of the following are reasonable management steps except one. Identify it. Option A, check adherence to omeprazole. Option B, perform endoscopy. Option C, increase omeprazole dose. Option D, start empirical Helicobacter pylori retreatment. Option E, assess for functional dyspepsia. The correct answer is option D, start empirical Helicobacter pylori retreatment. The explanation is that retreating Helicobacter pylori infection without confirmatory testing may lead to unnecessary antibiotic exposure and resistance. Instead, adherence and functional causes should be reviewed before further eradication therapy. Endoscopy and stepwise management based on evidence are preferred according to BNF guidance. Conclusion. That wraps up our revision on the therapeutics topic of dyspepsia. I hope this quiz has helped reinforce your understanding of key clinical decision-making principles and pharmacological strategies for managing dyspepsia in real-world scenarios. For those who'd like to explore the subject in more depth, I recommend Clinical Pharmacy and Therapeutics by Kate Whittlesey and Karen Hodson, as well as Clinical Pharmacology and Therapeutics by Ritter, Lewis, Mant, and Ferro, particularly the latest edition for updated evidence-based insights. Be sure also to consult the British National Formulary, BNF, as all recommendations in this video align with current BNF guidance.